Professor Whitty, if I could start with you. The NHS is never out of the headlines, as you know. Strikes, obviously another strike announced yesterday potentially by junior doctors about money, but as much we hear anyway about the system and the sheer demand on it, which of course hits staff very hard. We heard from GMB Union just before Christmas about 10 times the number of calls coming into the ambulance service. The Secretary of State told us about 100 times the number of people in hospital with flu this winter. We know the NHS in England spends more than £10 billion a year dealing with diabetes care, and there are so many more examples, obviously. Can I ask you to start this session, to start this inquiry, in your view, as our Chief Medical Officer, is the NHS sustainable in the future without a complete step change in how we prevent ill health?
Thank you, Chair. And because this is the first session of what I know is going to be quite an involved thing, do you mind if I give a relatively long answer to that, just to start it, to frame it?
I was hoping
my other questions will be, my other answers will be a lot shorter, but I just thought it might be helpful. Pretty clearly, the only way that you can, there are three things you can do to make the NHS more efficient and effective, and therefore for all of us as citizens and for those of us who work in it, make this able to work for the medium and long term. The first of them, which this inquiry is looking at, is prevent disease. A very large amount of the most severe disease is either preventable completely, can be pushed out in time so that people have it at a much later stage of their lives, or can be caught early, at which point it's a lot easier, much more pleasant, or at least less unpleasant to treat, and indeed cheaper to treat than if it's dealt with earlier. This is all the work of prevention. There are clearly then things we can do in terms of the NHS itself, how it's run, which I think is for obviously for other points in your inquiries. And then finally, and importantly, there's the issue of people who need social care following the NHS, which again is a very major part of the issue. All three of those are important, but I'm going to, this session is about the first of those, prevention.
Yes.
Prevention has an absolutely massive role in some diseases, has a significant role in some, and has almost no role in others, and it's important to lay those out, I think, and that's what I'd really like to do in my first few comments, and then we can take any of them in detail. Let's start off with an example of a disease which is almost entirely preventable, not completely, it's about 79% preventable. I'll take two cancers, and there are different sorts of prevention. The first cancer I'll take is cervical cancer largely in young women. This is something which we now can prevent almost all deaths if we look 10 to 30 years to the future, mainly by vaccination, because this is something which is driven by infection, and also by screening, because screening allows us to pick it up at such an early stage. It can be treated incredibly quickly as a day case, really minimal trauma for the women involved relative to if it goes on later. And Cancer Research UK would say this is essentially now 99% preventable once we look out to the future, once the cohort of girls who are vaccinated turn into women and into the period at risk. And then another cancer which is highly preventable is lung cancer. Lung cancer is our number one killer of a cancer. It's a horrible way to die. Most people who are diagnosed die within a year, very unpleasantly. 79% of all lung cancers are preventable. The great majority of that is caused by smoking. And then there are also some additional issues in terms of industrial processes and some issues in terms of air pollution as well. But the big one really is smoking. If smoking disappeared, the great majority of the worst of our cancers would just disappear. At the other extreme, the most common cancer in men, prostate cancer, there is nothing that we currently know that can be done actually to prevent it. There isn't an effective screening mechanism, there is no preventive systems. This is really all about early diagnosis and treatment. So I'm just making the point that there is a variety, depending which disease you're talking about, but actually the majority of the largest diseases we worry about, the cardiovascular diseases, heart attacks and cardiovascular disease, strokes, most of the cancers, for example, breast cancer, bowel cancer, we can either prevent them substantially or at least to a large enough degree to make a very big difference to people's lives and to the NHS. So there's a lot we can do. Just to take two examples, if I may, Chair, and then I'll obviously leave it to you.
And if you can bring in the point I'm making about sustainability of the NHS, given demand where it is.
Exactly. So I'm going to take the example I'm going to use is coronary heart disease. When I was training in medicine, coronary heart disease dominated the medical take. to a very large degree. 50% of people back in the 60s, I'm not that old, but back in the 60s, would have died of coronary heart disease in the UK. That rate has gone down to 25% of people will die of heart disease or cardiovascular disease now. That's a vast improvement, but actually also people are not getting the unstable angina, the major events that have put them into the NHS in the first place. Now, what has led to that improvement? It's broadly three sets of things. There's primary prevention. That's things which are done to everybody. We all as society do them. They have to be directed by political leaders who are elected. It's a societal choice. That's things like reducing smoking, reducing salt, improving areas for people to exercise, a variety of things which can be done to everybody, and that improves the cardiovascular health of the whole population. Then you have secondary prevention, and that's things which is done based on someone's individual risk. And this is true for all the diseases, but I'm taking heart disease as the example. And those are things like identifying that someone has hypertension, putting them on antihypertensive, they've got high cholesterol, they're on a cholesterol-lowering drug, or indeed they're individually smoking and helping them individually to come off because we failed to prevent smoking in the first place. And then finally there's treatment, and that's the bit which is, in a sense, that's beyond this inquiry. But the primary prevention probably was the principal reason for the big reductions we saw in cardiovascular disease from the 60s through to around about the 80s. And increasingly then secondary prevention became important. And if you look at people dying of heart disease, this is per 100,000 over time. For men, that's dropped from 1,280-ish to about 300 now. That's a very substantial improvement. And in women, it's dropped from about 889 down to 210 over that time period. And that's made up of a combination of lots of steps on primary prevention, lots of steps on secondary prevention, and improved treatment. It's when you put those together that you then get significantly better health and much less pressure on the NHS. So you have to kind of think, there are lots of things we do in primary, lots of things we do on secondary, and lots of things we do on treatment. Medicine is made up of lots of incremental steps, but a very large proportion of them for most diseases are on the preventative side. And then the final thing just to highlight is that within the UK, the prevention that we have is very badly distributed around the population. So if you look at our most deprived areas, the period of time people live in ill health and indeed how long they live is very significantly lower than our most affluent areas. That's clearly not biologically necessary. So to take a well-known example, in Blackpool, for example, people live 8 years shorter on average, varies hugely around the city, it's a lot of variety, but also more importantly in many ways, they live 19 years fewer years in good health. So they also, therefore, are living their lives in a very constrained way. And this is due to preventable things. And I'll just take two examples of that, and then I'll sort of see where the committee wants to go. One of them is smoking. Smoking, which drives a large proportion of the cardiovascular disease, the strokes and heart attacks, a large proportion of the cancers, not just lung cancer, but esophageal cancer, bladder cancer, many other cancers. That is twice as high, usually in people in lower incomes, more than twice as high in people living with mental health issues. The cigarette industry goes absolutely unerringly for the most vulnerable in society. And you have a situation where a great majority of people who smoke will have taken up smoking before they are 18, and almost all of them will have taken up smoking before they're 20, i.e. the cigarette industry goes to the most vulnerable teenagers. And it aims to addict them at that stage of their lives. And then when they find they can't come off, they're hooked. Most people who smoke don't want to smoke. This is framed by the cigarette industry as an issue of choice. Actually, they have deliberately taken the most vulnerable children and people in society and taken their choice away from them by addicting them at an early stage of their life. So that's one of the reasons the differences in deprivation. A second one is issues of obesity. So if you look at obesity in reception year, if you look at the highest and the lowest socioeconomic groups, at reception it would be people living with obesity would be a bit over 13% in the most deprived areas, and about 6% in the least deprived areas. By the time we get up to year 6, and remember these are still young children, it's 30% in the most deprived areas, and about between 13 and 14% in the least deprived areas. That's just two big drivers of ill health. So it's very heavily skewed towards areas of deprivation. I'll stop there, Chair, and take it in any direction you want.
Do you worry about the NHS and its viability given the trajectory that we're on? Because all the things you said about obesity, all the things you said about smoking, they're not being turned around, they're continuing. So do you worry, as CMO, about the viability of the NHS if it continues to have this level of demand into it? In a sense, my job is to try and see if we can improve it, and I think what is really clear is we can on this. On smoking, we can definitely improve things. We can improve things on air pollution. We might want to come back to that. We can improve things on exercise. There's lots of things we can do to do that. Obesity is the one that is going in the wrong direction on this one. It's a very major cause of multiple diseases. So that's a very significant one to aim for, but there are certainly things we can do to turn that tide that has been going up down over time. So my view is these preventable things can all be turned around if there is the will to do so. Okay, so that's what I guess we're trying to get at, is there. So in the British Medical Journal this month, you called for secondary prevention services to be restored and extended post-COVID. If I look at your annual conference speech to the Local Government Association a year ago next month, you said that many areas of public health had, quotes, either trodden water or gone backwards since the beginning of the pandemic. And you were referring specifically, I think, to smoking, obesity, alcoholism as growing public health issues. You called for a long-term and local approach to prevention. So the Secretary of State seems to agree with you that prevention is central to his mission. I wonder whether you think it is central to his mission and to this government's mission.
I think if you think about the primary prevention and the secondary prevention, I think it definitely should be. And the Secretary of State has made clear he says it is, and the Prime Minister has said it is. The primary prevention issues are largely ones of political choice.
Yes.
So that is really in this building, the decisions, and in local authority elected leaders as well, where decisions around things like smoking are made. So that is a political choice. And then there are issues of secondary prevention, which is what I was talking about in the BMJ. That is mainly around the distribution of resources in the NHS, in the broadest sense. So there's not just doctors and nurses, but also pharmacists, physios, others who work in the system. Certainly my view would be, and I think this is shared by most people, and this is the reason the NHS have very much swung behind this, is putting more resource into that secondary prevention within NHS would be a good investment for the future, because it would help to slow down the speed of the hamster wheel, which otherwise goes ever faster. And we really need to put a lot of emphasis on that area of medical care, nursing care, widest health care, as well as, in a sense, making the case politically, this is for ministers clearly to do, that there are choices to be made on primary prevention. And if Parliament chooses to enact some of the things it could do, we could improve things like air pollution, reduce things like smoking, and reduce the risks of obesity in the most vulnerable. So those are political choices.
But it's self-evident that those choices are not being made to the extent that you would like.
Correct.
Okay.
My job is to make the case that public health is important, so unsurprisingly, I think these are very important issues.
Yes. And then just finally, just in 5 minutes or so, then I'm going to bring in James Morris, who wants to talk to you about mental health. Your annual report last year made air pollution and its effect on health its central pillar of the report. It was good to see. And I know you've been in Parliament this morning talking to the all-party group about exactly that. We have a major issue with air pollution in this country and its driver of cardiovascular disease, and you've made the link with cancer. I just wonder if you would give us some of your thoughts on air pollution and how much of a low-hanging fruit that could be. Because, yes, we're interested in long-term preventative health measures, but we're also interested in what can we do in the short term to be able to do it.
So one of the points that the report made, I hope reasonably clearly, is that we have had an extraordinary improvement in air pollution over the last 30 to 40 years. And the two things that drive that, broadly, are engineers and politicians. It's a combination of those two groups who can lead on this. So if you take transport, for example, every decade the amount of nitrogen oxides and particulate matters has gone lower through cars. As we move to electrification, nitrogen oxides in transport will virtually disappear from at least the light vehicle fleet. There will still be issues of particulate matter from brakes and particularly tyres, and they need to be dealt with. But there have been significant improvements. There have been major improvements in industrial emissions of air pollutants. But we have not had the same kind of improvements in agriculture, and that's not a trivial issue, but probably not one at this point in the inquiry, but I think might be worth coming back to. What we have not done so effectively, in my view, is tackle indoor air pollution. And since that's where 80% of where people spend their time in industrialised countries, that's a major issue. But largely the problem there is one of we don't know what to do yet. The science is not settled. Whereas for outdoor air pollution, we do know what to do. And I think a lot of it is about accelerating down the curve, doing things that we know will work, including, for example, speeding up electrification of vehicles and a variety of other things I go through in some detail.
For the layperson listening then, what's a driver of indoor air pollution?
Well, indoor air pollution it's got three kind of drivers. It's got the stuff coming in from the outdoors, and that's why tackling outdoor air pollution is essential, because unless you've got that, you open the windows, things get worse. It's got indoor air pollution created in the home, and that can be as simple as things like the wrong sorts of air fresheners. People want to know that.
I see.
But then there's also ventilation, and here we've got a significant challenge, because we both want to have good ventilation. It's good for reducing air pollution, it's good for reducing infection, a variety of other things, but we also want to retain heat, particularly in winter, to reduce our carbon footprint, to reduce people's bills, and those two are potentially in conflict, and we've therefore got to find engineering solutions, back to engineers, to actually get those two resolved so that we can simultaneously have good ventilation to reduce air pollution and retain heat. That is a manageable engineering challenge, but it's one we haven't fully resolved at this point.
Okay.